Skin and subcutaneous tissue, benign lesions, sebaceous epidermoid cyst. Definition: retention cyst caused by blockage of a sebaceous gland duct. Pathology: lining by stratified squamous epithelium. Content: foul-smelling white material composed of keratin, epithelial cells, and granular debris. Clinical picture: type of the patient, rarely before adolescence. Symptoms: slowly growing cyst. Site: most commonly in scalp, face, neck, or scrotum, but can occur anywhere else except palm or sole of the foot, devoid of sebaceous glands. Signs: small, well-defined cystic swelling, which is usually attached to the skin at one point, which is the site of the punctum. The swelling is mobile over deep structures. Sometimes a sebaceous cyst attains a large size. The lesion may be solitary or multiple. Complications: infection. This is the commonest complication. Clinical picture: the cyst becomes painful and tender. There is overlying redness and abscess may form. Early cases may subside by antibiotics. If an abscess forms, incised for drainage, excision is delayed later as infection makes the cyst wall adherent to the surrounding tissues. Localized alopecia is the second complication. Treatment: complete cyst excision with an ellipse of overlying skin containing the punctum to avoid recurrence. If the cyst is small, we have local anesthesia. Dermoid cyst. Definition: cyst lined by stratified squamous epithelium and contains sebaceous material. Types: sequestration dermoid cyst, tubulodermoid cyst, teratomatous dermoid cyst, and implantation dermoid cyst. Sequestration dermoid cyst etiology: subcutaneous inclusion of portions of surface epithelium along the lines of fusion of cutaneous dermatomes during the fetal life. Time of presentation: after a few years when the cyst begins to distend, although present since birth. Sites: external angular at the outer angle of the eye, root of the nose, around the ear, and along the midline of the body. Clinical picture: well-defined globular cystic swelling not attached to skin. The underlying bone may be hollowed out and there may be connection to dura mater. Tubulodermoid cyst etiology: distension of remnants of embryonic ducts such as cyroglossal duct leading to cyroglossal cyst, cervical sinus, branchial cyst. Teratomatous dermoid cyst: benign forms of teratoma, lining squamous epithelium. Contents: teeth, hairs, bone, cartilage, or glands. Site: the ovary, most common, testis, and posterior mediastinum. Implantation of dermoid cyst etiology: secondary to punctured wounds, displace some epithelial cells into subcutaneous tissue, return their viability, and form a dermoid cyst. Site: fingers, mainly, palm, and sole. Clinical picture: they are usually small and tense. Treatment: surgical excision. In children with dermoid cyst in the scalp, wait until closure of the skull sutures as some cysts may communicate with the dura. Papilloma. Definition: benign tumor, usually pigmented, which commonly develops in large numbers in the face, arms, and upper trunk. Etiology: may be familial with autosomal dominant inheritance. Pathology: composed of immature epidermal cells nourished by elongated dermatopapillae. Course: malignant transformation is rare. Treatment: excision, cryosurgery, or cautery. Callosity. Definition: area of superficial thickening of the skin due to continuous friction. Site: mostly on toes and sole from wearing ill-fitting shoes. Fingers and hands of manual workers. Clinical picture: not painful, forms a circumscribed yellowish-white plaque. Sometimes an adventitious bursa may develop beneath it. If infected, an abscess is formed. Treatment: avoid causative agent if possible. Shave the callosity with a razor blade and repeatedly paint it with ointment containing salicylic acid. Corn: similar to callosity but a combination of friction and pressure. Example: tight shoes, downgrowth of a hard horny plug into the corium, pressure on sensory nerve endings, leading to much pain. Treatment: as callosity, excision, and suturing rarely is necessary. Wart. Etiology: viral infection. Mode of transmission: direct contact. Gains access through abrasion. Pathology: localized overgrowth of epidermis and papillae of skin. Clinically: small horny projection and maybe multiple. Treatment: whether by curettage and diathermy, repeated application of glacial acetic acid. Cryosurgery using whether liquid nitrogen or nitrous oxide. Keratoacanthoma or molluscum sebaceum. Etiology: exposure to the sun. Type of the patient: middle-aged persons. Pathology: composed of keratinizing squamous cells. Clinically: firm, rounded, reddish papule, enlarged rapidly over 8 weeks, leading to rounded, slightly umbilicated nodule, 1 to 2 cm in diameter. The center contains horny plug covered by a crust concealing a keratin-filled crater. Course: spontaneous healing takes 6 months by shedding of corny core. Clinical importance: mimic an epithelioma or a rodent ulcer, unnecessary surgery. Pathological examination: abrupt transition from normal to hyperplastic epithelium. Hemangioma, previously named as strawberry mark. Definition: benign proliferative neoplasm of vascular spaces in the endothelial lining. Incidence: affecting 10% of white infants, female to male ratio is 3:1. Majority lesions affect head and neck area. Stages: stage of proliferation shortly after birth, reddish patch which increases in size over the few following months. Involution phase starts at the end of the first year. Clinical picture: central pallor appears and color of the lesion slowly fades. There is progressive decrease in the size of the lesion, continues until the age of 10 years. Involuted phase: the skin becomes normal in about 50% of cases. Some residual changes as discoloration, scarring, or telangiectasia may persist. Complications: periorbital hemangioma may encroach on visual field. Serious bleeding from ruptured large liver hemangioma. Large cutaneous or visceral hemangioma leading to congestive heart failure. Intraplatelets leading to thrombocytopenia. Treatment: reassurance of the parents and observation are recommended. Skin appearance after involution is better than the scar following excision. When it's necessary to interfere, the following are helpful: oral or intralesional corticosteroids, laser photocoagulation, and surgical excision. Multiple terms were used to describe vascular anomalies as cavernous and strawberry. Current nomenclature is biologically based: hemangioma, vascular malformations such as low-flow lesions, capillary malformation, venous malformation, high-flow lesions, arterial and arteriovenous, and finally lymphatic malformations. And then we have vascular malformations. Definition: structural abnormalities in the blood vessels due to embryological error. Time of presentation: may be present at birth or later. They grow proportionately with the child and they don't regress or involute. Investigations: Doppler ultrasound, differentiate high flow from low flow lesions. MRI and or MRA, the most useful, assess extent of lesion and degree of involvement with surrounding. Angiography. Types: capillary malformation, port wine stain. Presentation: since birth and they don't undergo involution. Clinical picture: the lesion is dark purple and not raised above the surface. Applying pressure, blanching, but color returns immediately after release. Sometimes take the distribution of one of the branches of trigeminal nerve, but they don't cross the midline, sometimes associated with similar lesions in the meninges. Sturge-Weber syndrome. Treatment: pulsed dye laser of choice during childhood, requires general anesthesia and multiple sessions may be needed. YAG laser treatment during adulthood, results are not good as in children. Venous malformation, similar to hemangioma in clinical picture but usually appears later. As it's a malformation, it doesn't undergo involution. Treatment: percutaneous sclerosis with hypertonic saline, 100% alcohol or sodium tetradecyl sulfate. There is high recurrence rate, so multiple sessions are required. Surgical excision, preoperative embolization or sclerosis, facilitate hemostasis, and finally interstitial laser coagulation. Arterial malformations or cursoid aneurysm. Definition: abnormal development of arterial structures including stenosis or hypoplasia, duplication and or tortuosity, site in the scalp mostly, especially in the temporal or occipital regions, and may involve the underlying bone. Clinical picture: soft, compressible, and pulsatile swelling with marked bruit. Ulceration of underlying skin may occur. Serious hemorrhage. Treatment: difficult as the swelling is supplied by multiple feeding arteries which have to be ligated. Preliminary embolization of the feeding vessels may be tried. Arterial venous malformations. Definition: abnormal connections between arteries and veins without intervening capillary bed, high flow lesion. Presentation: at birth and may be not evident until late childhood. Clinical picture: localized AVM or arterial venous malformations, localized swelling with increased surface temperature. There may be palpable swirl or murmur. Diffuse AVMs, gross disturbance or skeletal distortion. Treatment: excision 1 day after embolization of feeding vessels. Extensive coverage by free flap may be needed. Hereditary hemorrhagic telangiectasia is an autosomal dominant disease characterized by multiple cutaneous, visceral, and mucosal AVMs. Lymphatic malformations, classification microcystic or macrocystic, may have component of venous malformation. Site: the head and neck region or the axilla, majority of cases. Neck masses may extend into the mediastinum or pectoral area. Consequences: congenital macroglossia, macrootia, Macrocalia or lip enlargement, scata involvement may cause distortion. Treatment: percutaneous aspiration followed by sclerosis, leading to short-term improvement and usually requires additional treatment. Surgical excision, multi-staged procedures, technically easier as child grows. Wait until at least 3 years of age. Lipoma. Definition: benign tumor which is composed of fatty tissue arranged in lobules. Pathology: gross picture. The tumor has lobulated surface, yellowish color, enclosed in a false, thin fibrous capsule, and can be inoculated. Microscopic picture may contain excess fibrous tissue, fibrolipoma, angiomatous tissue, angiolipoma, or myxomatous tissue, myxolipoma. Course: grows very slowly. Clinical picture: slittery, well-defined swelling, multiple lipomatosis, leading to multiple lipomas in limbs or trunk, differential diagnosis of multiple swellings. And then we have other types, classification according to the site. Subcutaneous lipomas, the commonest. The characters are slowly growing, painless, not tender, lobulated surface, may attach to skin at multiple points, consistency is soft, and some lipomas, especially in warm weather, may give pseudo-fluctuation due to mobility of the tumor in its bed, and fat at warm temperature undergo liquefaction. Well-defined, slippery edge as tumor moves inside the capsule. The swelling is mobile over deep structures. Subfacial lipomas under the deep fascia, not attached to skin and not have slippery edge, difficult to diagnose. Intermuscular lipomas, swelling is masked by overlying muscles, difficult to diagnose, fixed deeply. When the muscle contracts, disappear, become more prominent if they are pushed out of the muscle. Differential diagnosis: soft tissue sarcoma, and because they are hard and grow rapidly. Submucous lipomas, site, larynx, stomach, or intestine. A submucous lipoma in the larynx leading to respiratory obstruction, while in the intestine leading to intussusception or intestinal obstruction. Parosteal lipomas arise in relation to the skull and may cause bone erosion. Extradural lipomas found within the spinal canal, leading to paraplegia. Intra-articular lipomas, this is the final type. Complications: degeneration leading to calcification. Malignant transformation, which is very rare, may occur in retroperitoneal lipomas. A lipoma is generally a very innocent tumor which doesn't cause any problem except in submucous lipoma in the intestine or extradural lipoma of the spinal canal. Treatment: a subcutaneous lipoma is usually excised for cosmetic reasons. The operation is inoculation of the tumor from inside its capsule. Benign lesions of melanocytes or nevi. Origin: they develop from the neural crest and migrate to lodge between the basal cells of the epidermis. Their number per unit area of the skin is fixed irrespective of the race or skin coloration. Skin color differences are due to melanin granules amount. Melanoma: true malignant neoplasm which arises from melanocytes. Melanocytes can give rise to various hamartomas. Types of nevi: lentigo, junctional pigmented nevus, compound pigmented nevus, and intradermal pigmented nevus. Lentigo: melanocytes replace basal layer of epidermis over a certain area. Histologically: rounded cells containing fine granular brown melanin pigment. Clinically: pigmented, well-defined spot varying in color from pale brown to black. Junctional pigmented nevus: more proliferation of melanocytes, leading to small nodules of epidermis which bulge downwards into the dermis. Clinically, it looks like a lentigo. Compound pigmented nevus: eventually the basement membrane is disrupted. Some melanocytes pass to the dermis, lose their capacity to form melanin, and they are called nevus cells. In the dermis, varying number of macrophages containing melanin pigments are present. Clinical picture: raised above surface, variable in color from pale brown to black. Sometimes dark hairs are seen growing from the lesion surface. Rarely, extensive area of the skin is replaced by such hairy pigmented nevus, and it's called giant hairy nevus. Intradermal pigmented nevus: around the age of puberty, the majority of instances junctional activity ceases and nevus cells in the dermis undergo maturation. Most pigmented nevi of adults are of this type. Clinically, they look like compound pigmented nevi which may turn malignant. The giant hairy pigmented nevi: after puberty, any pigmented nevus with junctional activity has the potential to undergo malignant changes, but rare. And then we have indications for surgical excision for cosmetic reasons, and if they are subjected to repeated trauma during shaving. If there is suspicion of malignant transformation, adequate surgical excision should be performed and the specimen should be examined histologically. Precancerous skin lesions: Squamous keratosis, actinic or senile keratosis, site sun-exposed parts, particularly in fair-skinned people. Clinical picture: dry, rough, inelastic, and irregularly pigmented areas of skin. Histologically, areas of hyperkeratosis, nuclear pleomorphism, and increased mitosis with irregular cell differentiation, the most important precursor of invasive squamous cell carcinoma. Bowen's disease, site in non-exposed skin. Clinical picture: sharply demarcated, rounded, reddish patches slowly growing. Histologically, epidermal hyperplasia with cellular differentiation. The disease is usually treated for a long time as psoriasis. Malignant neoplasm of the skin, basal cell carcinoma or rodent ulcer, locally malignant lesion which arises from the basal cells of the epidermis. Incidence: the commonest malignant lesion of the skin, more common in males above the age of 40 years. Persons with light-colored complexion are more than those with dark skin, as the presence of melanin pigment protects against effects of ultraviolet rays. Etiology: prolonged exposure to sun, ultraviolet rays, this is the most important one, more common in farmers, sailors, and countrymen in sunny areas. Albinism and xeroderma pigmentosum, predisposed to multiple basal cell carcinoma all over the body. Ionizing radiation, patients receiving immunosuppression. Pathology: site in the face in 90% of the cases, especially above the line from the lobule of the ear to the angle of the mouth. The commonest: outer or inner eye canthus, nasolabial fold. Gross appearance: starts as small nodule covered by thin epidermis ulcerates, leading to serous discharge and bleeding. Occasionally, there are multiple lesions. Later, the patient usually presents by ulcerated mass or excavating type or other less common types. Ulcerated mass, edge is rolled in like a car tire and is beaded. Rate of growth very slow. After 1 year, the diameter increases by only 1 centimeter. Floor, red granular and most commonly covered with a dry crust or scape. Excavating type, ulcer erodes deeply into the underlying structures, leading to destruction and infiltration of the nasal sinuses. Other less common types: the cystic, the pigmented, containing melanocytes. The flat superficial spreading presents as red scaly patch, resembling psoriasis or eczema. Microscopic appearance: the tumor cells are arranged as sheets. Palisade appearance: the outer layer, low columnar cells with tall nuclei. Inside this layer, polyhedral cells with large basophilic nuclei. No tendency to keratinization, and mitotic figures are uncommon. Spread: only direct spread to the surrounding and underlying structures. If the draining lymph nodes are enlarged, secondary infection or presence of a focus of basosquamous carcinoma. Diagnosis: by a biopsy. If the lesion is small, excision biopsy. Large lesion, small piece of edge with an area and adjacent skin. Prognosis: excellent if the lesion has been completely excised. Cure rate is 100%. Recurrence is due to leaving behind foci of malignant tissue, more liable to occur if there is infiltration of bone or cartilage. Treatment: radiotherapy. Basal cell carcinoma is very radiosensitive. The dosage is fractionated over several weeks. Contraindications: involvement of underlying cartilage or bone. The lesion is near the eyes. Surgery indications: small lesion, as it's easy to close the defect. Infiltration of the underlying cartilage or bone, as it will protect malignant cells from the effect of radiotherapy, and radiation causes necrosis of involved bone and cartilage. Radioresistant lesions and recurrence after previous irradiation. Safety margin: 0.5 cm is adequate regarding surface and depth. Defect created after excision is closed by primary suture or by flaps. The pathologist should check that an adequate safety margin has been excised, and if not, reoperate or give radiotherapy. Other lines: cryosurgery and local application of cytotoxic drugs such as 5-FU cream or Effudex. Squamous cell carcinoma or epithelioma, incidence more common in males, especially elderly persons. Etiology: prolonged exposure to sun, ultraviolet rays, as in rodent ulcer. Previous irradiation. Albinism and xeroderma pigmentosum, long-standing irritation of the skin, as in chronic granulomas, chronic ulcers, osteomyelitis, sinuses, and old burn scars. Prolonged exposure to carcinogenic agents, as polycyclic hydrocarbons, coal tar derivatives, or mineral oils. Immunosuppression. A carcinoma on top of scar is called Marjolin's ulcer. Usually there is delay in its diagnosis. Pathology: site in the upper part of the face, lower lip, dorsum of the hands, sometimes arises at the mucocutaneous junction. Gross appearance: ulcerated mass which grows rapidly. Edges are raised and everted. Floor occupied by malignant fungating tissue. Base is indurated and it becomes rapidly fixed to the underlying tissues. Secondary infection may occur and there may be blood-stained discharge. Microscopic appearance, differentiated and in undifferentiated tumors. Differentiated characteristic appearance, which is called epithelial pearls or cell nests, outer precle cells and keratin in the center. As carcinoma cells enlarge, older cells in the center produce some keratin, lose their organelles, and become flattened and cornified, lie concentrically in the center of the mass, infiltrate the underlying connective tissue. In undifferentiated tumors, cells are anaplastic with basophilic cytoplasm, no origin evidence, spread direct to the adjacent structures rapidly, lymphatic to regional lymph nodes. Sometimes the nodes are enlarged due to secondary infection. Fibrosis associated with scarring in Marjorine's ulcer make lymphatic dissemination late. Bloodstream spread is very uncommon. Differential diagnosis, keratoacanthoma, basal cell carcinoma, and finally malignant melanoma. And then we have treatment, surgery and radiotherapy. Surgery indications, small lesions, excision biopsy with an adequate safety margin, infiltration of cartilage or bone, radioresistant lesions, recurrence after previous radiotherapy, Marjorine's ulcer, block dissection of metastatic lymph nodes. The safety margin for epithelioma is at least 2 cm except in the face where it's 1 cm. Prognosis, 90% success rate and 5-year cure rate. Radiotherapy indication, tumors of the head and neck, particularly for poorly differentiated lesions. The resulting scar is fragile. Melanoma incidence, increasing in Western countries, maybe due to defective ozone, almost unknown before puberty. Etiology, prolonged exposure to ultraviolet rays of the sun, albinism and xeroderma pigmentosum, on top of benign nevus. Pathology and clinical picture. We have comparison between the different types of melanomas, so we're gonna discuss them. Superficial spreading melanoma, incidence 64%, site in any part of the body, age, usually in middle age, character of the lesion, rays above the surface with irregular edge, and prognosis, good as malignant melanocytes spread along the epidermis, while nodular melanoma, incidence from 12 to 25%, site in any part of the body, age, usually in younger age groups, and character of the lesion, rays above surface, gray or black in color and liable to ulceration. Prognosis, bad as malignant cells invade the dermis. Lentigo maligna or Hutchinson's melanotic freckle, incidence 1 to 15%, site in the face, age, elderly persons. Character of the lesion begins as flat brown macule which grows very slowly. Some areas even regress. Least malignant as malignant cells spread along basal layer of the epidermis. Acrolentigenous melanoma, site, palms, soles and beneath the nail. Age, not specified. Character of the lesion, in the nail. Prognosis, poor. Amelanotic melanoma is of very poor prognosis. Then, prognostic factors. Prognostic factors are thickness of the tumor, Breslow classification, depth of invasion of the skin, Clark's level of invasion, epidermal, the best prognosis, dermoepidermal junction, superficial papillary derms, deep papillary derms, subcutaneous tissue, the worst prognosis, spread direct to subcutaneous tissue and the deep fascia, lymphatic by permeation or embolism, lymphatic permeation, satellite nodules around the tumor or between the tumor and the regional lymph nodes, blood to lungs, liver, bones, brain, and skin. Diagnosis by histological examination, the only sure method, how to take biopsy. The line of incision should meet the possible subsequent excision. Safety margin should be 3 mm, should include the whole skin subcutaneous tissue to allow pathologists to determine Clark's level and Breslow thickness. Paraffin section is better than frozen section. Treatment, surgical excision of the primary lesion with an adequate safety margin of the skin and subcutaneous tissue, but not including the deep fascia. If the tumor thickness is less than 1 mm, safety margin is 1 cm, 1 to 4 mm, safety margin is 2 cm, and if more than 4 mm, safety margin is 3 cm. If the regional lymph nodes are enlarged and firm, radical block dissection, free by clinical examination, sentinel lymph node biopsy. Prophylactic block dissection is no longer performed. Metastasis treated by chemotherapy, interferons, and interleukin-2. Malignant skin tumors of vascular origin. Kaposi sarcoma, origin from the endothelium of lymphatic and blood vessels. It may occur sporadic, endemic in certain countries in Africa and may have relation to cytomegalic virus infection, one of the immunosuppression manifestations associated with AIDS. The thicker and the deeper the lesion is in squamous cell carcinoma, the worse are the spread and prognosis. Malignant melanoma may rarely arise in eye, meninges, or at the mucocutaneous junction as the anal canal. Criteria of malignant transformation of benign nevus are increase in size or thickness, change in pigmentation, occurrence of itching, tingling, ulceration or bleeding, development of satellite nodules, differential diagnosis, granuloma, pigmented basal cell carcinoma, hemangioma, compound or junctional nevus, and finally, malignant melanoma can spread virtually to any organ by secondary deposits which are black. And this concludes our part for the skin and subcutaneous tissue.